Good morning. As we all know that glaucoma is one of the leading cause of irreversible blindness, and as a part of the World Glaucoma celebration, today we will be talking on MIGS, which is one of the newer modalities of treatment for patients with glaucoma. So the talk today will be MIGS, our experience. MIGS or Minimally Invasive Glaucoma Surgery is an ab interno approach through a clear corneal incision sparing the conjunctiva. So that is one of the major advantages where you spare the conjunctiva for a future trabeculectomy. So this procedure has minimal trauma to the target tissue. It has an IOP lowering efficacy, very high safety profile which avoids serious complications in other glaucoma surgeries which you see, and there is rapid recovery with minimal impact on the patient's quality of life. According to the FDA definition, MIGS is a type of IOP lowering device which is used to lower the IOP using an outflow mechanism with either an ab interno or an ab externo approach associated with little or no scleral dissection and minimal or no conjunctival manipulation. But according to the European Glaucoma Society guidelines, it's only an ab interno, non-bleb forming procedure which can be defined as MIGS. So the indications are that you want to reduce the IOP, but your goals have to be modest and early to moderate glaucomas. So you have to exclude advanced glaucomas and high pressures for MIGS surgery. So classification is you have trabecular bypass, trabeculotomy, goniotomy and viscodilatation, suprachoroidal implants and subconjunctival implants. So under the trabecular bypass you have the iStent inject, hydrus. Trabeculotomy, goniotomy, you have the trabectome, goniotome, GAT, and which is gonioscopy assisted transluminal trabeculotomy. You have the MIG-hook dual blade and you have the Tanito Micro-hook. In the trabeculotomy, goniotomy and viscodilatation, you have the surgical system Omni and Streamline. In the suprachoroidal implants, you have the CyPass, iStent Supra and Miniject, and in the subconjunctival, you have the Zen gel stents. So the MIGS, it works either on the Schlemm's canal, that is the conventional outflow in which you have the iStent inject, hydrus, trabectome and goniotomy. The ones which address the suprachoroidal space are the CyPass and the iStent Supra, and that which acts at the subconjunctival is the Zen implant. Contraindications for MIGS are primary or secondary angle closure glaucomas, neovascular glaucoma, angle dysgenesis, traumatic glaucomas, elevated episcleral venous pressure, lens-induced glaucoma, or wherever there is a media opacity, corneal edema, where you cannot have a good gonioscopic view. So a word about this Tanito Micro-hook. They can be used for goniotomy or trabeculotomy, goniosyncytialysis. So you have the two models available, the straight hook and the angled left hook and right hook. The straight hook usually helps to address the nasal angle, and the angled hooks you can go in from the nasal side and address the temporal angles. So they are designed with an oblique thick surface and has a circular edge for assessing and incising the trabecular meshwork. We've already talked about the three models. So it is an ambidextrous design, so helps to access the trabecular meshwork of the opposite angles. So the makers of Tanito's hook, they claim advantage over the MIG-hook blade is that it does not strip the trabecular meshwork. It separates the trabecular meshwork, preserving the trabecular meshwork. So that is the biggest advantage with it, that there is minimal damage to the target tissue. The tip is small compared to the MIG-hook's blade, so there is less chances of damage to the iris root and endothelium. It enters the TM without stripping it and reduces the tissue damage. So a word about our pilot study. It's a prospective interventional study. We included patients with ocular hypertension and glaucoma suspects. primary open angle glaucoma patients where the IOP was less than 30 millimeters of mercury. We excluded cases where there was corneal edema or opacities where we wouldn't get a good gonioscopic view, and any patients with history of intraocular surgery. So, in all the patients that we did, we combined it with a clear corneal phaco, but Tanito's micro-hook can be also used as a standalone procedure for doing goniotomy. So, the prerequisites are you need a direct gonioscope, and that is the Schwann-Jacob lens which we've used. And another important thing is the positioning of the patient. So, very important is we need to rotate the microscope towards the surgeon, as you can see in the picture, and rotate the patient's head away from the surgeon and ask the patient to look straight ahead. So, this is a case where we did a clear corneal phaco, and after the implantation of the intraocular lens, the Hilon-GV was placed on the surface of the cornea, and the direct lens is kept, gonio lens, to visualize the angle. So, you introduce the Tanito's micro-hook, and you can see the trabecular meshwork and the angle structures. So, you gently use the tip of the hook to cleave the trabecular meshwork away from the Schlemm's canal. So, you can see it's very gentle procedure. So, you are doing it without damaging the outer wall. So, the most important thing is once you strip the trabecular meshwork, it could lead to formation of leaflets, and that would undergo fibrosis and block the collector channels. So, the patient demographics, we did 27 eyes. The average of the age of the patient was 60 plus, and 15 males and 12 females were there in the study. The IOP range was between 21 to 28 millimeters of mercury. Pachymetry was done, and the cup disc ratio was such that we excluded all advanced glaucomas. And as already mentioned, we had ocular hypertensives, POAGs and NTGs in our study. So, we got a mean IOP reduction of about 26% on our day 1, and this was maintained on 1 month. The 3 months data we are still calculating, but we've got very encouraging results, and good drop has been noticed. Postoperative complications we faced were most common was corneal edema. There was also hyphema, and one patient had an IOP spike which subsided after 24 hours. A word about the other devices for goniotomy without an implant is the juxtacanalicular space slider, which is made by Ryko. It's a Z-shaped implant. Again, it is supposed to bring about a reduction in the intraocular pressure with minimal damage to the trabecular meshwork. So, it has a smooth surface which prevents tissues from being trapped between the irregularities of the surface. It is patent pending. And gonio scrub, this is also another device which is supposed to clear the debris from the trabecular meshwork. So, it causes a mechanical massaging of the meshwork, and is also supposed to stimulate the macrophages, somewhat similar to what results we get with SLT. So, the glaucoma treatment algorithm. Initially, we put the patient on one medication. If it is not under control, we go for multiple medications. Then we go for an SLT and a trab, and if the trab fails, we go for a second trab or a tube. But today with MIGS, so first is the medication, then you go for even drug delivery system, and MIGS has a role to play between the surgical intervention and your medical management. So, you go in for MIGS, and then later on you can go in for trab or tube depending on the intraocular pressure control. So, thank you. So, the results of MIGS have been encouraging, and we hope that it does have a good role to play in the management of glaucoma in future.